Hola, buenas tardes. Vamos a empezar la última ponencia del día, que nos la va a brindar el doctor Scott Murray. Esta mañana, cuando estábamos en el desarrollo de la muerte digna, algo que ha quedado así un poquito... Aparte de celebrar el triunfo del Atlético de Madrid, ¿no? Estuvimos ensayando los cánticos para irnos a las 7 a la Fuente, a Neptuno. Pues nos contó unos datos el doctor Rocafort que a mí me parecieron muy interesantes. Decían, al hablar de los criterios de calidad de atención en los últimos días, que aproximadamente, haciendo un estudio en el Estado español, en todo el territorio, solo un 30% de los enfermos en situación avanzada, con enfermedad terminal oncológica o no oncológica, recibían a día de hoy cuidados paliativos de alta calidad, que eran valorados también por equipos de cuidados paliativos específicos. Pero ese porcentaje, nos comentaba el doctor Rocafort, que cuando el paciente era terminal por cáncer, estaríamos hablando en torno a un 40 y tantos %, pero sin embargo, si el enfermo, la terminalidad era no cáncer, solo recibían cuidados paliativos de alta calidad, pues menos del 20%. Y yo sigo diciendo que ese es un gran vacío que tenemos. Desde hace 6, 7, 8 años estamos desde la SECPAL y desde diferentes sociedades científicas enarbolando la bandera de que los enfermos terminales no oncológicos tienen el mismo derecho a recibir cuidados paliativos, pero la realidad es que 6, 7, 8 años después siguen en clara inferioridad de condiciones. No me enrollo. Voy a presentar al doctor Scott Murray. Scott is a general practitioner and also professor of palliative care at Edinburgh University, Scotland. He leads the primary palliative care research hub. Their focus is not only on people with cancer, but with people with all types of advanced illness and the frail elderly. He's an editorial advisor to the British Medical Journal, chairs the International Primary Palliative Care Research Group, and regularly visits African countries where he used to work to conduct training and research. He's a board member of the International Association of Hospice and Palliative Care. Thanks so much.
Thank you very much for that kind introduction, and thank you very much to the organisers, especially Xavier, for having me across here to speak. It's a real pleasure to come in here. I've learned so much today. My brain is going like this. This is quite difficult for us. So what I'm going to do in the next 40 minutes, or maybe 30 minutes if you're lucky, it will be more about our concepts, how we think. That's why the subject is about clinical trajectories of people with advanced illness. So it's really just I'm going to talk about an idea and see how you respond to it, see how we can learn from that. But before I do that, I would like to make a plug for the International Primary Palliative Care Research Group. This is an international group. We have members from all over the world. You can see a list there, and that is the website there, which is a super resource. And the point of this group, and the people are here, you can see they come from throughout Europe and throughout the world. And if you are interested in taking forward palliative care in the community, this is where to be. Free membership of this group, and the group exists actually about advocacy. And the vision, okay, what this group believes is that we should care for people with all illnesses, on todas las enfermedades, and all illnesses, not just cancer, all times, okay, early palliative care, not just late. So we have a vision for 5 things. There's 5 points. All diseases. The second one is all moments. The third one is all dimensions, en todas las dimensiones. All dimensions of need, not just the physical, but straight through to the other 4. The fourth thing is on todos los settings. Okay, the excellence that we have in hospices, we have to get to all settings. And the fifth one, en todas las naciones, all nations. So that's something to learn. That's the vision that international group. We should take palliative care to all people, not just terminal, but early rather than later, all dimensions, all settings, and all nations. So remember those 5 points, okay? That's something that this group does, and I think we can do it all. And the role of this group is to advocate within specialist palliative care for how good primary care can use. To advocate also within primary care. Sometimes I go to primary care conferences to say, you guys, we should be researching palliative care. And we encourage palliative care research in the community. And we've got that web resource. And feel free, if you would like to email me or join in there, click on there, and you can learn. It's a great place. There are friends there that will help and encourage you to do this. So I've come from Scotland. There we go. This is the wee dog, Greyfriars Bobby, who used to go to his master's grave. He died, and every day he went trekking back faithfully to that grave for many, many months. But I mentioned again, okay? I'm going to talk about trajectories at the end of life, patterns of how we're dying. I'm going to use that to think how we can understand about these 5 key aspects. The real challenges for palliative care in the next 10 years, I believe, are these things, okay? All illnesses, all moments, all dimensions, all settings. The quality of palliative care should be as good in a care home as it is in a hospice, and all nations. So let's look at that. So let's think about dying, profile of people who die. 100 years ago, and still in Africa today, the average age of death is about 46, and people die of those main conditions: infectious diseases, accidents, or childbirth. And people can die all in a sentence very quickly. But nowadays, in Europe, we die older, and you can think of the ways or the different diseases in 3 main groups. And using these groups is a way of letting us know how we might design services that will help the groups. So nowadays, people tend to die of cancer, organ failure, various organ failures, COPD, heart failure, liver failure, renal failure, or the most common trajectory is this frailty or dementia. So it's physical frailty or cognitive frailty, which is dementia. And we take longer to die nowadays. And so you can look at these trajectories if you want, like this. And the top one is the blue one, where someone declines quite rapidly and predictably in the end, which is typically the acute decline, typically of cancer. The second trajectory, the organ failure one, is the ones where we have these blips on the way down, acute heart failure, say, go into hospital, come back. And the third one is gradual dwindling here. And that's the death rate today, guys. If you live, you die, 100%. And the more recent data is exactly the same. There is no improvement. Despite helicopters, despite everyone is still dying. It's a fact of life. I sat at the end of a bed 2 weeks ago, and I just sat. There was a lady in the bed there, and I sat, and it was so peaceful. And I was just sitting there witnessing that event. And it was such a time, and I really felt very strong about it. And you might think I'm sitting at a deathbed, but I wasn't. I was sitting at the end of the bed of my daughter, who had just delivered twins 2 weeks ago. It was lovely. I just sat there, and I enjoyed that moment, just witnessing that event. And that actually reminded me of sitting at the deathbed of people, just the joy nearly of actually helping and being and witnessing someone as they pass out. So we live and we die. And the next question I have for you is, I would like you to think for a moment and choose which way you might want to die of, okay? Because as a GP, I have 20 deaths a year. We have 2 sudden ones, 5 from cancer, 6 from organ failure, and 7 on this other trajectory, the dementia frailty one, okay? So, which would you go for if you had to make a choice? Who would go for... Hands up if you want to go for the acute one, the sudden heart attack. Put your hands up if you think you would like that one. I see a lady with a hand up here. Okay, now the bad news is that only 10% of people go that way nowadays, okay? So you cannot guarantee that you are going to go that way. To be realistic, you have to choose one of the other versions, okay? So to be realistic, you have to choose, would you nowadays, given how you are, how the services are, would you choose to die from cancer or organ failure or frailty? So I'm asking people to put their hands up if they would go for the cancer one. If you had to die, who would go the cancer way? Who would go for cancer? There's quite a few hands there, about a third, Why cancer? Why maybe cancer? Maybe because it's quite predictable, quite quick. One good reason is that the services are provided, okay? Palliative care tends to, 85% of palliative care is for people with cancer. Is that fair? It's not fair, is it? Palliative care, should it be according to diagnosis? No. Should it be according to prognosis? Probably not. According to need or capacity to benefit, okay? So the point is that cancer is the clever choice just now because the services are there. But we should, in case I die of frailty, okay, we should all try to make services as good as they can so we can have a good death, whatever we end up dying from. And so that's the challenge then about, and that's why we're talking about trajectories. We can use that as a way of understanding how we could try to better care for people who are dying on the other illnesses. This lady with organ failure, for instance, she has many problems. And she is on this trajectory of decline. She is physically well, but then she comes to a stage when she's possibly needing more than just physical care. And one trigger or change gear of that could be the admissions to hospital. So there's a time when she needs supportive and palliative care. She needs active supportive care. So there are 3 stages that we can describe in organ failure where chronic illness care is fine, but then the next transition is into supportive and palliative care. And then there's a third transition into terminal care, the care in the last days or week of life, when a care pathway such as the Liverpool Care Pathway can be used. So there are ways of thinking of when we could start giving a supportive approach as well as giving disease-modifying treatment. Similarly, in COPD, we've looked at that illness as well, and there are triggers that you can look for when someone might have that, although it's slightly more difficult in COPD for various reasons. Similarly, in heart failure, no one's done a longitudinal study on the lived experience of someone dying with liver failure, and we've got a team at our unit just now looking at that. Which type of trajectory that will be? We're not sure. But here's an old lady from Ireland she's on the frailty trajectory. Now, I asked her, because she was actually one of my patients, I said, where would you like to be cared for if you got more ill? In other words, where might she want to die? And she looked at me and she said, where do you think she had never been out of her house for 2 years? Where do you think she would like to die? You might think, at home. No, she said, in hospital. I said, in hospital? Why hospital? She said, that's where Seamus went. That's where her husband went. That's where the nurses are, okay? That's where she thinks. So her choice of going to hospital is really, that's where the care was. So again, I'm trying to identify it. There's an inequality, and we should try to help people at the end of life in palliative care for all illnesses, not just cancer, but organ failure and frailty. So why bother thinking about these patterns or trajectories of decline? Well, it lets us think of 3 groupings so that we can define services, and we can have not a service for heart people or COPD people, but there might be a service that very well is configured or makes up to meet the needs of people on that trajectory, and then another service for the frailty trajectory. And they also tell us that things are changing, things are dynamic at the end of life. We also know they're a bit unpredictable, and what we're trying to say is there is a typical one, but it's not always that. Like someone might have a heart attack, and there's a classic presentation that clinicians know about what is a heart attack. But by knowing what is typical, we can understand the slightly unusual. Right. So that was something about all illnesses. And let's just talk for a minute about how can we, the second point of starting palliative care earlier than later. Because the old model of palliative care was that we cured as long as we could, and then we went into palliative care. No more can be done. We heard that terrible phrase before, and then we went here. But now the idea is that at diagnosis of a life-threatening illness, such as lung cancer, we start a palliative approach, supportive and palliative care approach, and gradually increase it throughout the course of the illness. And that's the model, and you can see with cancer how that could be implemented reasonably well. But what with Organ failure, I've hinted again that we can use these trigger points such as admission to hospital, or a trigger point could be breathlessness at rest. There are other ones that could be used, and we've described those in the BMJ a couple of years ago as to what triggers could be for the different illnesses. And of course, we've heard a bit of this surprise question, which is also there in the SECPAL. But the question is, pretend you have got a lady with organ failure who has had various admissions to hospital. You ask yourself, would I be surprised if that patient were to die in the next 12 months? And the answer is normally, no, I wouldn't be surprised. You don't expect her to die within 6 months. Therefore, she is not in the category, the classic category that gets palliative care. And therefore, she is not being identified for the extra support that she surely needs. But this question is a way just to let people suddenly think, hey, this patient maybe needs extra support. And that's the utility of that question, okay? And if you wouldn't be surprised, well, if you wouldn't be surprised, that means she might die. And if you're a good nurse or if you're a good doctor and your patient might die, you will probably want to have a little cunning plan just in case she dies, so you know what to do. Because if she starts dying and you haven't made a plan, you'll feel you won't know what to do, she'll feel insecure, but if you've made a plan, you'll feel more comfortable and you'll be better. So that is one question that has been used a lot, increasingly in primary care. And we've also used it in hospital wards in Edinburgh there. And hospital doctors can also identify people using this question. However, they use other types of indicators. And an indicator I was doing, we had a paper out in BMJ Heart last week, in fact, showing that the Seattle questionnaire that cardiologists use only shows 5% of people will die in the next year, when actually 40% actually die. So you can see that their indicators are not working. This prognostic question shows 80%. So the answer is in the middle, so we have got a little work here. And we have to avoid this prognostic paralysis. The idea of if we don't know, if prognostication is so difficult, we have to not stop chasing the holy grail. Just do not go there. Don't waste our time doing nothing because we don't know what. If we don't know, we should just go ahead and make a plan. And there's a tool that we call it the Supportive and Palliative Care Indicator Tool, one that we've developed in Scotland. And note, it's not about prognosis, this tool. It's about identifying people who might benefit from supportive and palliative care. And we've got the word supportive there because I can put someone on this, I can use this tool to identify people who need more support. And I can say, I think you need some more support. Can I put you in the register? And people will say, yes, that's fine. But if I start talking about palliative care, doctors and nurses find it a difficult word to use. So it's quite important to be careful as to the vocabulary we're using here. And that's it, actually. You will not read that, but I show you it like this because it's just one side of A4. And it's a tool that could be used and is being used in primary care in Scotland just now to identify people. And it might be that you're seeing someone in a busy surgery and all you have to think, would I be surprised, wouldn't be surprised, make a tick and flag up this person for further identification. And here's someone who was identified. This gentleman had many admissions with emphysema. And he had a bad chest, and he had ischemic heart disease, and he had many things, and he had frequent admissions to hospital. And then, for 2 years, what happened was he was identified for this approach, and from then, he had really no more admissions for 2 years until he finally died. And it shows you that just being identified, I said to him, you're identified, we will give you more support. In fact, we said to him, you are a gold patient at our practice. Like giving someone a gold card. And so he could phone up and say, Dr. Murray says, I'm a gold patient, can I speak? And so being called like that gave them a feeling, yes, they were cared for, and they could then continue to be cared for at home. So identification is a very important factor. And just like the SECPAL, we are now, this tool called the SPICT is being used in various different practices throughout the UK and even in some hospital wards as a way, and we're trying to test it, just as the SPICT is being done to work out how many people it actually identifies. And yes, I did want to show, because this SPICT tool that Xavier and others are now using, especially in Catalonia and throughout Spain, is actually an excellent further development on the prognostic indicator guide that Kerry Thomas did and my own one. And I'm very pleased at the way that this one is going forward. And in fact, it is building on our tools. For instance, it actually mentions something about family and team members. and we were just at a meeting there. Of course, someone should be identified as support if they don't have someone at home to support them. So there's a very good reason why people who are maybe living alone that could be one of the reasons, among others, why they could possibly be identified for support. And having this comorbidity idea. When I teach medical students, we talk about what do most people die of nowadays? And the answer, in fact, is it's multimorbidity. Yeah, that's a clever answer, because most people now die with 2 or 3. They've had time to collect a number of illnesses. But this SECPAL is currently being validated, and it starts, as we know, from chronic lists, people with chronic illnesses, looking to identify more people where the clinician might not be surprised if this person would die in the next year or so. And then there's some other parameters. And what this means is that we can then identify people who wouldn't otherwise be identified for a palliative care approach. So what is a palliative care approach? It's basically holistic care and planning ahead. Because these people are not being identified for basically coordination, and therefore they don't get coordination. And that's, I think, a large aspect of what we can actually help with. And early work with the SECPAL, I'm delighted to see, is it's identifying about 2% of the population. Because we know that 1% of a population dies every year if people die at average age 80. So the number we should be, the indicative prevalence, the number of people that it might be sensible to look for who might be in their last phase of life is about 1 or 2%. Because it's really about helping people in their last phase of life. With cancer, that may be weeks or months. If with organ failure, it's sometimes months or years. And with frailty, it can even be longer. And some cancers, such as prostatic cancer, there's quite often a prolonged dwindling phase, isn't there? And so they are going along the frailty trajectory rather than the cancer one. So these are typical things. But remember, we're trying to help people, not according to cancer only, not according to prognosis, but people who need support in their last phase of life. We identify them, and then the basic thing is we assess and make a plan, and that's what it's all about. And making a plan is difficult, and there are often cultural reasons. GPs, we found in Britain, are very good at the terminal care in the last days of life, but we tend not to do the advanced care planning so much. People would say, GPs would say, well, we maybe don't do this in case the patient loses hope. Although our research does show that a lot of people really want the opportunity to benefit, to talk about the end of life. What's the most important issues in your life right now? If things got worse, where would you like to be cared for? Is another question. I was reminded earlier to think of do people want to talk about the future? That's quite a difficult question. We certainly shouldn't force people to do that. But some research that we've done in Edinburgh, where we've interviewed people every few months with various illnesses, have shown that actually people in the back of they've got a thing called competing narratives. They've got 2 stories in the back of their head. If you go up to someone and you say, "How are you today?" they'll say, "I'm fine." So they've got the "I'm getting better" narrative. Okay, that's the restitution narrative, and most people would say that's their public account. But most people who have brushed with death, maybe had a heart attack or got cancer, as well as the "I'm getting better" doc one, if you went up to them and says, "You seem fine today, but tell me, are there ever days when you're not so well?" And if we sit down and let them talk, about 85% of people will say, "Yeah, funny you mentioned that, but I have thought about that and these other aspects." So that just means that just because someone today says, "I don't want to talk," they may at some other time do want to talk a bit about the future. Not necessarily about dying or whatever, but just something about the future. And that's just one intervention we did. We actually identified, this was in our care homes, all nursing homes in our region beside Edinburgh. We decided to do advanced care planning on everyone being admitted to a care home with nurses. We said that this is routine good care. And we found that by doing that, we increased the number of do not attempt resuscitation documented, and we decreased admissions to hospital by about 50% in that region. So the hospital doctors were very happy. And that meant there were a lot less futile treatment. because resuscitating someone who's about to die, or a hospital admission for some people where it's not relevant, is futile treatment. So that shows that thinking ahead, and a trigger could be everyone who's admitted to a nursing home. That itself could be SECPAL positive, for instance. But let me press on. I want to go back now to the theme of trajectories, because we've talked about physical decline, but in palliative care we know there are various dimensions of need. At least these four here: physical, psychological, spiritual, and social. And just a word about what I mean by spiritual needs. It's now recognized that everyone, because we're a human, if we're faced with a serious illness, we think about the meaning and purpose of life. There's an accepted definition used by ourselves and researchers in the States relating to this secular definition of spiritual distress about meaning and purpose of life. Most people don't use religious vocabulary just now, so they can't use that to define this. And a spiritual issue becomes spiritual distress when it causes them a problem. And we would reckon that if people have a spiritual distress, it would increase the call on medical demand, as we've printed there. So that's just what I mean by spiritual needs. So let's talk a little bit about what's happening in the different dimensions as people die. Dying is a four-dimensional activity, right? Is dying a physical activity or is it a spiritual one? I think if you were a minister, you might say death is basically a spiritual event because we maybe live after them. So it's just to say that, there are different aspects. There's a phrase in Scottish: if I have a hammer, everything is a nail. So if you're a doctor or a nurse, you'll be thinking of medical things. But the main issue that someone may have might be somewhere totally else. So the only way to know is, of course, to ask them. So what we did, we had done a number of in-depth qualitative studies asking about the main issues that people had in their last months of life. And then we did a thing called a meta-synthesis where we brought together various qualitative studies together. And in each question, in each study, we'd been asking people what their main issue was at different times in life, whether it was medical, physical, psychological, or spiritual. We didn't ask them in these categories, but when they were speaking, we analysed what they were saying according to those sort of emerging themes. So let's look at some of the findings we had. So the red line is the classic physical trajectory. So I'm looking at lung cancer here. What we noted that there was a decline in social well-being that tended to mimic or go down in parallel with the physical one. So there's no numbers attached to these. These are just graphs to help us think. And the point of these is to think things are dynamically. And there's a quotation from someone: his old friends won't even take a cup of tea with me. Now I've got cancer. So what's happening here is that people aren't visiting. And generally, throughout the data, although there were some exceptions, people's social life tended to dwindle a bit. Sometimes there were more people maybe came to visit, but 10 folk didn't get out. And so there tended to be a physical trajectory of decline and a social trajectory of decline. Okay, are you with me so far? Because I'm going to try to map out the other trajectories, which may be even sort of trickier. So what's happening psychologically? Someone at diagnosis of lung cancer to death, when will the greatest psychological anxiety or depression be? What do we think? Will it start high up? We haven't time. But these are some quotations which seem to show. We actually found that there were 4 times when, if you want, psychological distress as opposed to well-being was greatest. So at diagnosis or just coming to diagnosis, people getting home at recurrence and at the end were times when quite often people were quite distressed psychologically. So living with uncertainty, someone being told, hey, you've got lung cancer, you could imagine that's quite a stressful time. But then here's a quotation: great nurses and departments, they're so caring. So typically people were going with the treatment and they felt less anxious. And then they got home after treatment and it was like a black hole, maybe no one to speak to. And then felt it a bit better again, and then the lung cancer might recur. And then there would be a dip again there. It's much worse the second time. So you can see there tended to be a fluctuation, depending on various things, but there tended to be 4 times like this. And we had a recent study of people with glioma, and there was findings like this. And in fact, the most acute distress was not actually at diagnosis or recurrence. It was waiting for histology. It was before the diagnosis was made. Yeah, and in palliative care nowadays, psychological support tends to be all at the end of life. The hospice, nothing up front. So there's a point here about showing that this is to do with time. So that's psychological. Let's think about existential. What might be happening in someone's existential distress? And we've found that the same thing was happening, because at diagnosis, someone was maybe saying, hey, why have I got lung cancer? Where is God in all this? So the existential issues tend to run in parallel with the psychological ones in this sort of time, tending to be worse at diagnosis, recurrence, going and at death. And the other trajectory went down like that. So these are the first time I think we've seen these things mapped out. It's a qualitative way. But and here's actually a picture, again, in the BMJ more recently, looking at spiritual distress. And there are some quotations that I'll just press over. But sometimes it's hard to differentiate between anxiety or existential angst. But often we know that if people are talking about the meaning and purpose of things, if they talk about how they feel about themselves, about how they feel about the ones they love, how they feel about God, that could actually be an existential issue. These are the type of people that don't need Prozac. They don't need antidepressant tablets. They need spiritual support. And how do we give spiritual support, you might ask? I asked an old lady that, in our research study, we actually said spiritual support. We said, we asked the lady, how do you get spiritual support? Letting that lady work out what I was trying to ask. So she defined what I was asking about it. It was a grounded way of asking it. And do you know what that lady said? She said, it's when the nurse comes down and sits and listens to me. So sitting with someone and valuing them as an individual is a way of giving general support. Yes, you can get specialist spiritual support from specialists, but surely we can, just by sitting and listening, can support. And of course, if someone's anxious, it also helps there. And we would, and other papers would suggest that you can see here that what we're trying to say is that if there is, where's number 1, unmet spiritual needs can lead to spiritual distress, and that increases the use of physical and emotional symptoms, and that then leads to increased use of the health services. So there can be a spiral. And so if we ignore spiritual distress, that can spiral up and impact in all the other dimensions of need. And this is an area that's hardest to research, but it's one that we ignore our power, and surely we should be remembering that this spiritual trajectory is important. Not for everyone, but it may be there. And just a quick word about multidimensional trajectories in organ failure. And just one slide here, but this shows you that there's various things going on, happening here. So there's the physical is the red, there's a quick drip here, but we've also discovered that there's also there's anxiety at that time, and often a social problem. Because a typical problem in the UK, the most common admission to hospital, a wife would get on the phone and and phone to the nurse out of hours and says, I'm awful worried. My husband, he's got COPD. He's very breathless. Yeah, I'm worried my husband's breathless. Now, what's happening there is, yes, the husband has got a physical problem, but the wife's worried, and he will also be worried, anxious as well, and there may be a social problem. So you can see, thinking about the multidimensional things that are going on allows us to realize the typical physical response of shipping the person in to hospital might not be the most appropriate one. And that if we had a service provided by palliative care or someone where we could prevent or acutely meet needs in these other dimensions, it would surely prevent an awful lot of admissions for people in this illness trajectory. And finally, on the theme of trajectories, because that's what I've been asked to speak to, we looked at what's happening in the dimensions of need for family carers, relatives of people who have got lung cancer or glioma, for instance. And we weren't very surprised, but we had hundreds of interviews with these people as well. And there's no surprise that if your husband or the one you love has got cancer and is going through all this, the spouse, the relative, has the same type of helter-skelter time. They are anxious and depressed. And so, again, we wrote this one up as issues in the carer. And they're not always like this, but the point of trying to show these as trajectories is to so things go up and down. If someone's got cancer, they just don't get more depressed and die. Far be from it. In fact, our research would suggest that resilience, that people tend to be less anxious just towards the last days than they are at initial diagnosis. And a recent study, this was published last month in the Canadian Medical Journal, again, where we're looking at people with glioma. And there are some practical points, there's some reasons why these trajectories can be helpful. Because, for instance, at referral, we're saying, acknowledge the distress of uncertainty while waiting for a diagnosis. That's what patients want. You know, often clinicians just don't acknowledge that. What they want is to say, this must be awful worrying for you, but you'll get sorted out first. And as a GP, if I'm sending someone out who I think might have lung cancer, I can say to them, hey, you'll be worried just now. You'll feel a bit better once we get the treatment going. But after then, come back and see me, because you might be worried. We can foretell the different dimensions of need that a patient may have and alert them about it. That will empower them, tell their carers about it, and make plans so that we can give appropriate care. And there's other information. So these are guidelines for clinicians that were published in Canada. Offer more detailed information about the likely process of what will happen. It's interesting, we heard this morning about people often don't want to know what's going to happen to them, and that's true, but people often want to know what happens to patients who have the conditions like they've got, you know. So what they want is information of the process or procedural information. So quite often I say, hey, do you want to know what normally, you know, how it pans out for most people with your condition? Most people say yes. So that's a way of giving someone information that isn't quite so personalized and they may find quite acceptable to get. That sort of procedural information, because most people want to know the procedure. And there's some other points there that this was other triggers that we heard from there. Right, I'm just going to press on because we talked about all nations, and this just shows a study because I used to work as a missionary doctor in Africa when I was a young lad. And after I had come back and I was starting to research in palliative care, my colleague was out in Africa, and we got nurses in Africa to interview people there who were dying of advanced cancers, different cancers there, what their main problems were. So we asked them in the local language. There in Scotland, we asked them, what's your main problem? In Kenya, we asked, which is the local language, for what's your biggest problem, allowing them to pick whether it was physical or social or whatever. And the results were quite different in the different countries. The main problem in Edinburgh, in Scotland, of having lung cancer around diagnosis was just, why have I got it? It was existential, possibly because pain was dealt with. But the main problem, the biggest problem, was physical in Kenya, especially pain, or I have no money to paint things. In Scotland, analgesia is effective, but it's unaffordable in most parts of rural Kenya even today. And in Scotland, most people often they're angry and keep it to themselves. Whereas in Kenya, there's an acceptance often rather than anger, generally speaking. There are exceptions. There was a great community support out there. People would visit with maize and beans or eggs. They wouldn't, I'm not visiting now, I don't want to talk, but people would visit. There was a great community support. There was a great spiritual support. People comforted and inspired more people being religious out there, believe themselves, and the local church would support. So the bottom line of this comparative study, again, which we published in the BMJ 10 years ago, was that in Scotland, the pain relief, the physical symptoms are dealt with well, but people have a lot of problems in the other three dimensions. Whereas in Africa, physical symptoms, big problem, but we can actually learn a lot in countries such as we have, where people could actually be cared for better, where we could get more involved. So that means there are different trajectories. So this illustrates that trajectories can be very culturally dependent. And we're doing further studies on illness trajectories in different types of places, such as Uganda. We're looking at this illness longitudinal qualitative work in the frail elderly people that has not yet been done, to ask them about their experiences of health services. They usually totally forget any health services they're getting, in fact. So that's quite interesting. And we're looking at some sort of trajectory that might represent multimorbidity. But because I was talking about Africa, there's a thing called health-promoting palliative care. I just want to mention it to you. And this is a booklet that a general practitioner in Australia gives out to people when they are diagnosed that they might die. Okay. Then the bottom line is, okay, things are looking bad, but if you're going to die, let's make the most of it anyway. Being very upfront about it. Okay, let's do our best. It's a grim situation, you've got a bad card, let's make the most about it. So imagine getting this living and dying in style. That's the concept. The person's going to die. We can't prevent that. We accept it, but we can prevent avoidable distress at the end of life. So that's what health-promoting palliative care is. We're promoting a healthy death. We're trying to prevent unnecessary distress. And unnecessary distress can be caused by a lot of things, such as stigma. And in England just now, there's a coalition of people, doctors, lawyers, called Dying Matters. And that's the Logos. Let's talk about it. And in Scotland, we have a vision just now. We want to be, and this has just started this year, a society which deals with dying and bereavement in a healthy and constructive way. Maybe I'm being a bit white Anglo-Saxon. We were talking this morning about cultures and stuff like that. But this is what Africa is, actually. It's a society which deals with dying in a very healthy and constructive way. Death is seen as part of life, okay? We are born, we pay taxes, and we die, okay? 100%. We're all going to die. Let's face up. Let's man up to it, if you want, okay? It's a challenge, okay? It's a challenge we can face or a challenge we can ignore. And if we can say to the public, here's a challenge, are we going to rise to it? Where the public and health and social care workers are of awareness of the many ways in which communities and individuals can support each other. Great things happening in Africa, great things happening in southern India, about people actually going out in communities and helping each other dying, not just in charity shops to raise money for palliative care, but getting involved in actual things. The key message about our coalition, this is in Scotland, we call it good life, good death, good grief. And we're playing on a pun there. Good life, so we're going to have a good life, and then we're going to have a good death, and then we're going to have a good grief. And there's a phrase in Scotland, good grief. That must be terrible. So that's what we're trying to do. So if someone is going to die, if they're NECPAL positive, okay, let them have a good life until they die. Let them die well, and let there be good grief. We should normalize. Death is normal. I've sort of made that point, okay, that death is normal. Thinking about death while we're young means there's less to think about it if you get sick. I think most people would understand that, yeah? And coming to terms with our own mortality can help us live life to the full. And there's various true aspects of that, I'm sure. If we think about it, it can help. And there are things individuals and communities can actively do to help each other. And I was across in Luxembourg last week, actually. Luxembourg want to be the healthiest country in the world. And I suggested, and so there are various people up there saying, what could we do to be more healthy? And I said, you could do the end-of-life bit better. And so I talked a bit about this, and this is totally against what people in Luxembourg think about. But the challenge was there to actually create a public discourse about death and dying in the society, so that even I have 2 PhD students in this subject of health promoting palliative care just now. And one intervention is to go into school classes to destigmatize dying. Before children are sensitized how bad dying is, just getting it there. And that's working. We have permission of parents and teachers so that we can get this discourse about death, dying in culture. Because probably the culture will get it before some oncologists, if you want. Sorry, oncologists present. So, I'm finishing. We've talked about trajectories, eh? If you look at the title there, do you see that one? Yeah. Oh, patron decline. So there's the physical trajectory. We've talked about 3 types of trajectories. The first, there are 3 types of physical decline at the end of life. None of us are going to die of, 1 or 2 might die of a heart attack, but we're going to end up on one of these trajectories, guys. And it's our job to ensure that whatever we are going to die of, things will be in position so that we can actually get a good death. There's a sort of personal thing about it. But think about trajectories allows us to think about services that can meet that. The second lot of trajectories I mentioned were about different dimensions of need, and that lets us think a bit about the future. It lets us plan that dying is slightly complicated. This is just the beginning of drafting these type of concepts, and I hope some of you might want to take it further. The trajectories in bereavement, they could quite easily be done. They've never been done pictured like this. That would make a super PhD for someone about how are these things happening in bereavement. And the third lot of trajectories, we thought about the family carer, the one that's close with something, because they also are going through a helter and skelter. And especially for primary care people, we have got these people to care for afterwards. So, cheers, that's the bottom line. There are trajectories, 3 different types of trajectories, and remember the 5 things. Remember, we have to care for people of all illnesses, all times, earlier than later, all dimensions, physical, psychological, social, and spiritual. What was the 4th all? All settings, yeah? All settings. And the 5th one, let's have a vision for the rest of the world. You guys are getting Spain sorted out. And I think Spain actually is now leading, especially in primary care and public health, is now leading the world. You've overtaken England. I can say that because I'm Scottish. But I'm very serious. If you guys get going, I think Spain is leading things just now. And finally, if you want to publish your documents, there's a new journal that we launched last year in Scotland. It's called the British Medical Journal Supportive and Palliative Care. And this is a good place to publish because it's the first year. It will have an impact factor very soon. But we are looking for publications. It is out of the British Medical Journal stable, so it is well done. And this journal itself is looking for a meeting ground between specialists and journalists, and this is where to publish. Okay, 50% chance of getting things in. I'm on the board, so if you want any assistance, feel free to let that know. But thank you very much for listening. And remember, 3 types of trajectories and 5 different types of dimensions. That's the future for palliative care. Thank you.
Vamos muy bien de tiempo, porque los ponentes que tenemos son magníficos. Yo creo que tendríamos 5 minutos o 10 minutos para preguntarle al doctor Murray. Any questions in the room? ¿No? El que pregunte tiene un descuento en la cena de mañana. Bueno, pues yo creo que está la gente muy cansada y vamos a dar por concluida la sesión. ¿Vale, doctor Murray?
Okay. Thank you very much indeed. All the best.